Today, we're going to explore a topic that affects millions of people globally, some through recreational use, others for medicinal purposes, and that is cannabis, often referred to as marijuana. More importantly, we're going to dive deep into how cannabis interacts with the human brain and body, and what science, real, peer-reviewed neuroscience, tells us about this complex relationship. Now, let's be clear. This is not a conversation rooted in moral judgment or politics. Instead, it's a conversation built on biology. My goal is to empower you with knowledge so you can make informed decisions, whether for yourself or those you care about. It's as if you suddenly installed a different operating system on your brain's computer without optimizing it for compatibility. Chronic exposure to THC has longer-term effects. The brain, recognizing that it's receiving too much CB1 activation externally, starts to compensate. It does this by downregulating the number of CB1 receptors, essentially reducing their density and sensitivity. This process is known as receptor downregulation and desensitization. The practical outcome is tolerance. The user needs more THC to get the same effect. But it doesn't stop there. Because the system has been pushed out of balance, when THC use is suddenly stopped, it can lead to withdrawal symptoms, irritability, anxiety, sleep disruption, and reduced appetite, until the body readjusts. Moreover, these neuroadaptations have broader cognitive consequences. With CB1 receptors dampened, the brain becomes less efficient at regulating neurotransmitter release. This has a ripple effect, particularly on dopamine and GABA, two systems that are critical for motivation, reward, inhibition, and stress regulation. This may partially explain why chronic cannabis users often report feeling flat, less motivated, or cognitively foggy when they are not under the influence. There's also evidence suggesting that repeated hijacking of the endocannabinoid system during adolescence, a critical period of brain development, can lead to permanent changes in synaptic pruning, myelination, and receptor expression. That's because the endocannabinoid system plays a major role in shaping brain circuits during development. Interfering with this process by saturating CB1 receptors with THC may alter how those circuits form, leading to long-term changes in behavior, memory, and emotional regulation. Importantly, all of this is dose-dependent. Occasional, low-dose use has a very different neural footprint than chronic, high-potency use. The THC concentrations in today's cannabis strains are often 3 to 5 times higher than what was available 2 or 3 decades ago, and this amplifies the disruption to the endocannabinoid system. In summary, THC doesn't merely enhance or relax the brain. It overrides a finely tuned biological system that exists to keep your neural activity in balance. While this can lead to one of the most well-established effects of cannabis use is its impact on memory, particularly short-term memory and the process of learning new information. This is not merely anecdotal, it is supported by decades of research in neuroscience and behavioral studies. And the mechanism by which this occurs ties directly back to how cannabis affects a very specific and crucial part of the brain, the hippocampus. The hippocampus is located in the medial temporal lobe and plays a central role in the consolidation of new memories. It doesn't just store memories, it's responsible for transforming experiences and sensory inputs into long-term representations that we can later recall. In other words, if you can't effectively encode or consolidate information via the hippocampus, you'll have a much harder time learning, remembering names, or recalling what you read in the morning by the evening. Cannabis, particularly its psychoactive component THC, tetrahydronaban, has a profound effect on hippocampal function. This is because the hippocampus is rich in CB1 receptors, the very receptors that THC binds to and activates. When THC enters the system and interacts with these receptors, it disrupts the normal communication between neurons in this region. One of the key outcomes of this disruption is a reduction in long-term potentiation, LTP. Long-term potentiation is the process by which synaptic connections become stronger through repeated activation. It's essentially the neurophysiological foundation of learning. When LTP is impaired, the brain's ability to create durable memory traces is diminished. This explains why people under the influence of cannabis may struggle to retain conversations, follow complex arguments, or remember details they just encountered. This is not just a transient effect. While acute THC use impairs short-term memory during intoxication, chronic or repeated use can lead to more persistent memory deficits. Studies have shown that regular cannabis users, especially those who began using during adolescence, tend to perform worse on tasks involving verbal memory, attention, and executive function, even when they are sober. Some of these deficits can persist for weeks or months after cessation of use, and in some cases, particularly when cannabis use begins early in life, the impairments may be long-lasting or even permanent. This raises an important point about age of first exposure. The adolescent brain is not fully developed, particularly in regions like the hippocampus and prefrontal cortex. During adolescence, the brain undergoes significant structural and functional. One of the most commonly cited reasons people use cannabis is to reduce stress and anxiety. Many report that using cannabis helps them feel relaxed, socially at ease, and less mentally overwhelmed. On the surface, this seems simple. THC enters the system, binds to cannabinoid receptors, and produces a calming effect. But if we look at what the neuroscience actually tells us, the relationship between cannabis and anxiety is far more nuanced. It is what's known as a biphasic effect, meaning the same substance can have opposite effects depending on the dose, frequency, individual biology, and context of use. To understand this, it helps to first recognize how the body and brain process threat and safety signals. The amygdala is the region of the brain responsible for detecting fear, assessing threats, and triggering physiological responses such as increased heart rate, cortisol release, and the activation of the sympathetic nervous system, our so-called fight-or-flight system. This is also an area where CB1 receptors, the primary targets of THC, are densely located. THC binding to CB1 receptors in the amygdala can reduce its activity. That's why low doses of cannabis, particularly in people who are already experiencing high baseline anxiety, may result in a decrease in anxiety. In other words, at low doses, THC can act as an anxiolytic, a compound that reduces anxiety, by suppressing hyperactive neural firing in the threat detection circuits of the brain. However, this effect doesn't scale linearly. As THC dosage increases, or as cannabis is consumed more frequently or through high-potency delivery methods, such as concentrates or edibles, a reversal of effect can occur. The calming effect may shift into something very different: heightened vigilance, restlessness, paranoia, or even full-blown panic attacks. At higher doses, THC can actually increase amygdala activity and disrupt the regulatory input from the prefrontal cortex, which normally helps us assess the rationality or irrationality of our fears. When this regulatory control is disrupted, a person may experience ordinary stimuli, such as a facial expression, a sound, or a passing thought, as profoundly threatening, even if there's no external danger. This is one reason cannabis-induced paranoia is so common, particularly in less experienced users or those who consume large quantities. What's happening biologically is that the normal inhibition between the frontal cortex and amygdala is being overridden. THC at higher doses may also increase cortisol levels and heart rate, further amplifying the physiological sensation of anxiety. So while cannabis may feel relaxing at first, it can, under certain conditions, shift toward amplifying anxiety and discomfort, the exact opposite of the intended effect. It's also worth discussing individual differences. Not everyone responds to cannabis the same way. People with certain genetic predispositions, particularly variations in the COMT gene or those with a family history of anxiety disorders, trauma, or psychosis, are more likely to experience the anxiety-amplifying effects of THC. Age is another factor. Adolescents and young adults are generally more sensitive to these effects due to their developing brain circuits and heightened emotional reactivity. Additionally, the set and setting, a term borrowed from psychedelic research, also matter greatly in the cannabis experience. Set refers to the user's mindset, their expectations, emotional state, and mental health at the time of use. Setting refers to the physical and social environment. A calm, safe environment can reduce the risk of anxiety, while a chaotic or unfamiliar setting can amplify it. There's also the interaction between THC and CBD, cannabidiol, to consider. Unlike THC, CBD does not bind strongly to CB1 receptors and actually appears to modulate or buffer the effects of THC on anxiety. Several studies have shown that cannabis strains or products that contain balanced ratios of THC to CBD are less likely to provoke anxiety than those that are THC dominant. Unfortunately, many of today's commercially available cannabis products, particularly in recreational markets, are bred to contain extremely high levels of THC with minimal CBD, increasing the likelihood of negative psychological effects. Importantly, chronic users may develop a tolerance to the calming effects of THC and start needing higher doses to achieve the same result. This can lead to a cycle where increasing use leads to heightened baseline anxiety, followed by more cannabis consumption in an attempt to relieve it, a neurobiological feedback loop that reinforces dependence and potentially worsens the very condition it was intended to treat. In summary, the interaction between cannabis and anxiety is not binary, it's dynamic and dose-dependent. Low doses may reduce anxiety in some individuals under the right conditions, while high doses, chronic use, or certain biological profiles can amplify anxiety, impair stress regulation, and trigger panic responses. Understanding the biphasic nature of THC and the individual variability in response is critical for making informed decisions about cannabis use, especially for those seeking to manage anxiety or mental health conditions. Cannabis has long been associated with relaxation, creativity, and introspection. But one of the lesser discussed, yet critically important, effects of chronic cannabis use is its impact on motivation and the dopamine system, which governs drive, effort, and reward anticipation. In many ways, understanding this relationship is key to decoding what people describe as a motivational syndrome, a state often characterized by reduced goal-directed behavior, decreased productivity, and a general lack of enthusiasm toward future-oriented tasks. To begin unpacking this, we have to look at the role of dopamine, a neuromodulator produced primarily in the ventral tegmental area, VTA, and substantia nigra of the brain. Dopamine doesn't simply make us feel pleasure. More accurately, it assigns value to goals and tasks. It signals that something is worth pursuing and energizes us to act. Dopamine rises in anticipation of a reward, not necessarily at the point of receiving it. This is why motivation is tied more closely to dopaminergic projections to the prefrontal cortex and nucleus accumbens than to the immediate experience of pleasure. THC, the primary psychoactive ingredient in cannabis, affects this reward system in both acute and chronic ways. Acutely, THC use leads to a temporary increase in dopamine levels in the striatum. This is one reason why cannabis can feel rewarding, euphoric, and calming in the moment. It's giving a short-term boost to the brain's reward circuitry. But that's only half the picture. With repeated, long-term use, the dopaminergic system begins to downregulate. In other words, the brain adjusts to frequent artificial stimulation of dopamine by decreasing its own production or reducing receptor sensitivity. This is a classic feature of many drugs that interact with the reward system. Over time, the same dose of cannabis produces less effect, and more importantly, the brain becomes less responsive to cannabis, despite the controversy surrounding its use, has well-documented therapeutic benefits when applied under the right conditions, in appropriate doses, and with medical oversight. The scientific and clinical literature supports its efficacy in several specific domains. But what often gets lost in public discourse is that therapeutic use is not the same as chronic, high-dose recreational use. The context in which cannabis is used determines whether it acts as a medicine, or contributes to dysfunction. To start with, the endocannabinoid system, which consists of CB1 and CB2 receptors, endogenous ligands like anandamide and 2-AG, and regulatory enzymes like FAH, is one of the body's master regulators. It maintains homeostasis across many physiological systems, including pain signaling, immune response, mood, appetite, and sleep. When the body's own cannabinoid system is deficient or dysregulated, something known as endocannabinoid deficiency, introducing external cannabinoids, such as THC or CBD, can help restore balance. This is the foundation for cannabis-based medicine. Among the clearest examples of therapeutic benefit is the management of chronic pain. Multiple studies have shown that cannabinoids, particularly THC and CBD in combination, can reduce neuropathic pain, pain that originates from nerve damage, more effectively than some traditional analgesics. In fact, countries like Canada and several U.S. states have approved cannabis for this exact purpose. THC reduces pain signaling by altering CB1 activity in both peripheral nerves and the spinal cord, while CBD may modulate inflammation via CB2 receptors on immune cells. This makes it particularly useful for conditions such as fibromyalgia, multiple sclerosis, and post-chemotherapy nerve damage. Another validated area is nausea and vomiting, particularly related to chemotherapy-induced nausea, CINV. Cannabinoids can act on the brainstem's vomiting center, helping reduce severe nausea that often doesn't respond to standard antiemetic drugs. A synthetic THC analog, dronabinol, is FDA approved for this purpose. What's important here is that the therapeutic effect comes at a low to moderate dose, and the objective is symptom control, not intoxication. Cannabis also plays a significant role in managing epilepsy, especially in children with rare forms like Dravet syndrome and Lennox-Gastaut syndrome. In these cases, it's not THC, but CBD, that shows therapeutic potential. Epidiolex, a purified form of cannabidiol, is FDA approved and has demonstrated significant reductions in seizure frequency. CBD is non-intoxicating and doesn't bind to CB1 receptors in the same way THC does. Instead, it modulates multiple systems, including GABA, serotonin, and intracellular calcium signaling, likely contributing to its anticonvulsant effects. Beyond these approved uses, there is growing interest in cannabis for sleep disorders, anxiety, and PTSD. The research here is still developing. Some studies suggest that cannabis may help individuals fall asleep faster or reduce nightmares in PTSD patients. However, these benefits are often short-term, and chronic use may worsen sleep architecture over time by suppressing REM sleep, which is essential for memory consolidation and emotional regulation. Again, dose and frequency are key. Low or intermittent use might help, but heavy daily use often backfires. An important nuance is the ratio of THC to CBD in therapeutic formulations. Medical cannabis is often designed with balanced or CBD-dominant ratios, unlike many recreational products which are heavily skewed toward high THC content. That balance matters greatly. CBD can buffer the psychoactive and anxiety-inducing effects of THC and reduce the risk of side effects like paranoia or cognitive fog. It also extends the therapeutic window, meaning the range at which a substance is effective without being harmful. There's also promise in using cannabinoids for inflammatory conditions such as Crohn's disease, rheumatoid arthritis, and autoimmune disorders. CB2 receptors, predominantly located on immune cells, regulate inflammatory cytokine production. Animal studies and early-phase clinical trials suggest cannabinoids can dampen excessive immune responses. However, long-term effects on immune function and the risk of immunosuppression still need more investigation. One area that deserves strong caution is self-prescribing cannabis. Just because cannabis is natural or plant-derived does not mean it is universally safe. Like any drug, it carries side effects, risk of dependence, and interactions with other medications. The therapeutic applications of cannabis require careful consideration of dose, delivery method, timing, and patient history. Smoking, for example, introduces combustion byproducts that may damage lung tissue, whereas sublingual oils or capsules provide a more controlled and safer method of administration. Importantly, cannabis is not a cure-all. It is not appropriate for every condition or every person. For example, individuals with a family history of psychosis or bipolar disorder may be at increased risk of adverse psychiatric reactions, especially with high THC formulations. In those cases, even small amounts can act as a trigger for latent symptoms. To summarize, cannabis can be a legitimate therapeutic tool when used under medical supervision, in targeted applications, and in controlled doses. It has demonstrated benefits in areas like pain, nausea, epilepsy, and possibly inflammation and sleep. But the same compound that offers relief in one context can cause dysfunction in another. Like any pharmacological tool, its value depends entirely on how it is used, why it is used, and who is using it. Knowledge, not assumption, should guide that decision. When examining the effects of cannabis on the brain and body, one of the most overlooked yet critically important factors is individual variability. Not everyone responds to cannabis in the same way, and this difference is not merely psychological. It's rooted in biology, specifically age-related brain development and genetic predispositions. Understanding who is more vulnerable to cannabis-related side effects and long-term consequences is essential for anyone making decisions about its use, particularly for adolescents and individuals with a family history of mental health conditions. Let's begin with age, especially during adolescence. The human brain continues to develop into the mid-20s, with the prefrontal cortex, the region responsible for judgment, impulse control, long-term planning, and risk assessment, being one of the last areas to fully mature. During this period, the brain is highly plastic, meaning it is more sensitive to environmental influences, including substances like cannabis. Introducing THC, the primary psychoactive component in cannabis, during this critical window of development has been shown to interfere with key processes such as synaptic pruning, myelination, and circuit refinement. These are essential tasks that shape how the adult brain functions long-term. When THC binds to CB1 receptors in the developing brain, especially in the prefrontal cortex and hippocampus, it disrupts normal signaling patterns that guide emotional regulation, decision-making, and memory consolidation. Longitudinal studies support this concern. Adolescents who begin using cannabis regularly show higher rates of cognitive decline, reduced academic achievement, and a greater likelihood of experiencing psychiatric symptoms such as anxiety, depression, or in more severe cases, psychosis. Importantly, the risk appears to increase the earlier cannabis use begins and the more frequent the use becomes. The adolescent brain is not simply a smaller version of the adult brain, it is a different brain entirely, more susceptible to disruption and less resilient to damage. In addition to age, genetics play a powerful role in determining how someone responds to cannabis. One of the most studied genetic factors is the COMT gene, catecholomethyltransferase, which is involved in the breakdown of dopamine in the prefrontal cortex. Individuals with certain variants of this gene, particularly the VAL-A-VAL genotype, have been shown to be more likely to experience psychosis-like symptoms when exposed to high levels of THC, especially during adolescence. Similarly, variations in the AKT1 gene, which affects dopamine signaling pathways, have been linked to an increased risk of developing cannabis-induced psychosis. This does not mean cannabis causes psychosis directly in everyone, but for individuals with a genetic predisposition, cannabis can act as a trigger, accelerating the onset of symptoms or worsening their severity. These symptoms can range from mild paranoia or anxiety to more severe disruptions in perception and thinking. There is also evidence suggesting that certain individuals are more prone to cannabis use disorder, a condition characterized by tolerance, withdrawal, and compulsive use, based on genetic traits that affect impulsivity, reward sensitivity, and stress reactivity. These traits may be influenced by polymorphisms in genes related to the dopamine, endocannabinoid, and serotonin systems. Sex-based differences are another layer of biological variability. Males and females tend to metabolize THC differently and show differences in cannabinoid receptor density and sensitivity. Some studies suggest that females may be more vulnerable to the anxiogenic, anxiety-producing effects of THC, while males may be more likely to develop dependence. Hormonal cycles in females may also interact with cannabinoid signaling in complex ways, making responses less predictable across time. Environmental factors compound these risks. For example, individuals who have experienced early life trauma or chronic stress often have dysregulated stress response systems. When cannabis is used in these populations, it can amplify emotional reactivity or destabilize mood. This interaction between environmental stresses and cannabis use is particularly dangerous during the teenage years, when emotional regulation systems are still forming. It's worth emphasizing that many cannabis-related risks are dose and frequency dependent. While occasional, low-dose use may not result in long-term harm for most adults, high-frequency use, especially with modern high-potency strains, significantly increases the biological burden on vulnerable individuals. Today's cannabis products often contain THC concentrations of 20 to 30% or more, far higher than the 3 to 5% typically found in products just 2 or 3 decades ago. This increase in potency drastically changes the pharmacological impact, particularly in sensitive populations. The good news is that awareness of individual differences allows for informed decision-making. For adolescents, delaying initiation of cannabis use until after the brain has matured greatly reduces long-term risk. For individuals with a family history of psychosis or mood disorders, avoiding high-THC cannabis altogether may be the safest choice. And for those who choose to use cannabis therapeutically, working with a healthcare provider to manage dosage, cannabinoid ratios, e.g., THC, CBD, and timing can significantly reduce the likelihood of negative outcomes. In summary, the effects of cannabis are not universal. Age, genetics, sex, psychological history, and environmental background all play powerful roles in determining how cannabis interacts with the brain and body. Recognizing these factors is not about promoting fear, it's about applying biological literacy to make choices that align with long-term mental and physical health.